Myself, Devidashri, Satyaprabha, and Sneha. We are going to present a case of Mr. X, a 54-year-old female from Kulashekram, housewife by occupation, came with the chief complaints of difficulty in walking, slurring of speech, deviation of angle of mouth to left, and inability to close right eye for 1 month. History of presenting illness: Mrs. X, a 54-year-old female who's known hypertensive with poor drug compliance, was apparently normal 1 month ago. One evening by 6:45 p.m., while attending a church gathering, she developed headache, which is acute in onset, severe in intensity, crushing type, involving the whole head, associated with heaviness of head, followed by sensation of rotation of surrounding, blurring of vision, lasting for 1 to 2 seconds, immediately followed by a fall. There was no associated head injury. She was then carried by attendant in an auto to nearby hospital. On the way, she developed cough while drinking water and vomited, which contained only food particles. In the hospital, she had some difficulty in lifting her left upper and lower limbs, but she could move her right limbs normally. Then they noticed her speech was slurred and angle of mouth deviated to left side. She was then referred to higher center where imaging was done and followed by treatment, and she improved. Bystander attempted to make her walk to bathroom with support, but she had unsteadiness on walking and she was swaying to left side. That night, bystander also noticed that she was unable to close her right eye. The next day, she swayed to left on sitting. She had difficulty in holding objects in her left hand, difficulty in buttoning and unbuttoning her dress. Bystander noticed outward deviation in her left eye. After 4 days, she started to walk with the help of bystander. Her swaying reduced. She had difficulty in maneuvering the left foot into slippers, and they noticed slippage of slippers from her left foot. Then she got discharged. 3 to 4 days after discharge, while watching television, she had double vision, which disappeared on closing one eye and improved after 2 weeks. All other symptoms improved, but swaying to left side, slurring of speech, and deviation of angle of mouth to left persisted. She then brought it for further management. There was no history of loss of consciousness, convulsions, and memory disturbance. There was no history of loss of smell, loss of vision, drooping of eyelids, loss of sensation over face, loss of taste, ear pain or discharge, hoarseness of voice, nasal regurgitation. There was no history of buckling of knees while walking, difficulty in turning from side to side, and difficulty in appreciating hot and cold sensation. There was no history of loss of sensation, appreciation of sensation of clothes over body, cotton wool sensation, pin needle sensation, burning sensation, and tingling.
The previous page on the slide, keeping in mind what are the symptoms of your patient, why do you want to ask the first and second is? Tell me the reason behind clinical relevance. Keeping in mind your patient's presentation.
So for loss of no history of loss of consciousness and convulsions, I thought of hemorrhagic etiology. So to rule out that, I asked for convulsion history.
Hemorrhagic always produces convulsion.
So there is increased ICT.
Basically, you are trying to look for any evidence of increased intratension. Then second point.
And for no
you mentioned complete history-wise, so many no histories, even the previous presenters also. You want to understand why you ask this.
Then for second point is for to rule out cranial nerves, loss of smell, loss of vision, drooping of eyelids, loss of sensation over face, taste sensation, ear pain and discharge, hoarseness of voice and nasal regurgitation, cranial nerves.
Which suppose is there, which of the nerves can be involved in your patient? Keeping in mind the site of involvement, what you are trying to reach at, of these symptoms which can be expected. Are you expecting smell disturbance? Loss of vision? No? Okay, drooping eyelids?
It can be, sir.
So where do you want to fix the disease in your first presentation of your patient? The initial 2-3 slides which you projected. What is your understanding of where do you want to focus the disease?
She has
is it the anterior part of the brain or posterior
part of the brain? Because she has dyspnea and she developed
dyspnea.
not dizziness,
Ah,
and diplopia was present, sir. Bystander noticed on my watching TV. This R3 our slurred speech is present, sir. Swaying to left side.
East to west you said. And
She was
weakness
not
also.
unsteadiness on
Weakness also you said.
weakness was
Proximal, distal also you said.
present. Distal weakness is present.
Not able to hold the
Hold the
slippers,
slippers.
slipping away of the slippers you mentioned about.
So I can posterior circulation.
Which part of the posterior circulation?
Brainstem is involved, sir. In brainstem,
Brainstem is involved. What are the points for brainstem involvement?
so for pons and
So
cerebellum,
brainstem is a big one, right? Even though structure is very, very small,
it contains methylene
multiple
pons.
structures are there.
So there was double vision.
Is a diplopia. So,
Which all graininess was double vision.
sir, 3 4
3, 4. 3, 4 means midbrain, 6 means small. Of which what do you think? Midbrain or 6? 3, 4 or 6? Ptosis not regular.
No.
Ptosis was not the
3 and 8 because ptosis.
so 6th
Which movement caused double vision? Looking which side?
She said right side. Right.
on
The right side she can develop.
double vision.
If it is 6th now, then I said pons or midbrain.
Pons.
Pons.
6th.
Will you able to explain the swaying? You mentioned swaying,
Swaying to
weakness, the pontine level with the sixth nerve involvement. Can you explain?
Weakness
I'm
of
just asking you to recollect whatever we learned last 2 cases. Just think about and then visually can answer. You don't get it.
weakness can be also due to coordination of the cerebellum.
Cerebellum involvement.
Coordination.
Coordination you said, okay.
Incoordination.
So will you able to explain the diplopia in that case? If cerebellum is involved, will you able to explain the eye movement involvement? What about others? Can also answer. Or helper to answer. Okay, we'll move on. Move on. See, go ahead.
There was no increase in swaying while closing eyes for washing face. There was no history of loss of bowel control, constipation and diarrhea. There was no history of increased frequency of micturition, urgency, dripping of urine, painful micturition. There was no history of tremulousness of limbs while reaching out for objects, no history of smearing of face with food. There was no history of abnormal posturing, violent cringing movements of limbs, dance-like movements. And past history, no history of similar episodes in the past. She is a known case of hypertensive for past 2 years and is on irregular medication, tablet enalapril 5 mg BD. Not a known case of diabetes, no history of dyslipidemia, bronchial asthma, epilepsy and tuberculosis. No history of cardiac disease, any other drug intake, previous surgery, bleeding diathesis and blood transfusion. Personal history, non-vegetarian diet, not a smoker, not an alcoholic, no bowel and bladder disturbances, no sleep disturbances. Menstrual history, attained menarche at 15 years of age, married at 21 years of age, first childbirth at 23 years, menopause attained at 50 years of age. Summary, a 54-year female patient, known hypertensive for 2 years with poor drug compliance. 1 month back, she developed headache, vomiting, blurring of vision followed by fall. She had difficulty in lifting up her left upper and lower limbs, slurring of speech and angle of mouth deviated to left side, for which she got admitted and treated in a nearby hospital. That night, they noticed that she was unable to close her right eye. Next day, she swayed to left while walking with support as well as in sitting posture. She had difficulty in holding objects in her left hand. All other symptoms improved, but swaying to left, slurring of speech, deviation of angle of mouth to left persisted. She then brought here for further management. From the above history, the probable diagnosis is acute stroke syndrome. With posterior circulation stroke, it can be.
So you think there is facial palsy on right side? The symptoms are there on left side.
Swaying to left.
It is something like a cross.
Left side hemiplegia. That's That's what you said. But still upper limb, lower limb involvement, right?
Yes,
Weakness and
right.
swaying,
Yes,
right? And facial involvement. So where do you want to use this? Why she get diplopia in this case? Now you're trying to fix the
Diplopia is looking to the right or left?
I'm looking to the right.
Right. That means what are the muscles you need to look to the right? The right lateral
Right
and left
lateral
medial.
medial.
So either suppose diplopia occurs on looking to the right means
Right
either there's a
lateral.
right lateral occurs or left medial. So in this case, it is more likely to be a right lateral. So right 6 on the right 7 on the left hemiparietal zone. That is the typical miliar tubular.
So you're able to explain now? You're able to explain now. So left side, upper and lower.
Now one question, right lateral rectus or left medial rectus or any test is available clinical website test. Have you heard of rub blast test? Rub blast. Anybody can stand up and tell about this rub blast test. And then what is the original white glass way? Rub glass way. So you keep rub glass, transparent rub glass on one eye, transparent white glass, plain glass on other, and then afterwards you look at the white. Then he will get two images. One image is the outer image. Actually there is only one image, but patient will say there are two images. So here the false image, but outer image is
Distant images.
false image is always the outer image.
Image.
We will see one will be seen in red color, other will be seen in normal color. Red glass is red image. Red glass is white image. We see which is the outer. Suppose red image is outer and red glass is on right, means there is right lateral. And there are two images. Red glass you can place on either side. Whichever image is the outer image is called. Is it possible for any other site of lesion for the same side cerebellar side, same side seventh nerve and same side 6th? In this case, it is crossed. So you said it is brainstem. I am telling another scenario where patient is getting cerebellar side on right side, 7 on right side, 6 on right side, 8 also on right side. Any other site of lesion?
Where is the area? Yeah.
Pons.
It's not truly on the pons.
There is an angle.
Cerebellar
CP angle. What is the anatomical structure that lies in CP angle? Actually, 8th nerve exits from pons and comes in an angle called CP angle. In this angle, 7th nerve will accompany the 8th nerve. But the 7th nerve and 8th nerve together enters the internal auditory meatus. And the 6th nerve also is lying nearby. So when there is a tumor of this CP angle, usually what is the commonest tumor? Tumor of the 8th nerve called acoustic neuron can compress the anatomical structures compress it. Compress 7th nerve on that side, 8th nerve on that side, and cerebellum also on that side. So you get same side cerebellar side, same side 7, and same side 8. And patient will get deafness, tinnitus, vertigo, 7th nerve also on one side, and cerebellar side also on side. Everything will be on side. That is, then you are taking off this acoustic neuron. But in this case, since it is crossed, it is like be inside the nerve. Pons is something is interaxial. CP angle is extraaxial. Cranial lesions can occur at 3 levels. Supranuclear, nuclear, and infranuclear. UMN lesions are supranuclear. Pontine lesions are nuclear. Whereas CP angle is infranuclear. There are 3 levels. It can occur at 3 levels. CP angle is an infranuclear lesion. Suppose you get a parotid tumor or a CP angle, everything, mastoid tumor, everything are infranuclear. Pons is nuclear. And UMN lesion, first case usually supranuclear. UMN. Supranuclear alone is UMN. Both nuclear and infranuclear are alike.
All of you able to follow our discussion?
Coming to the general examination, she is conscious, cooperative, oriented to time, place and person, comfortable, moderately built and nourished, no paranicterus, clubbing, cyanosis, significant generalized lymphadenopathy, no edema, no neurocutaneous markers. Vitals,
What is the relevance of neurocutaneous marker in a CP angle tumor? There are 2 types of neurofibroma. Type 1 type.
neurofibromatosis 1. One neuropeptides, one is associated with neurokinases marker.
One. The one can get peripheral. Two-wheeler left, CPI.
Pulse rate 68 beats per minute, regular in rhythm, normal volume, no specific character, no radial delay and no radiofemoral delay. All peripheral pulses felt equally on both sides. Condition of vessel walls are normal. Carotid felt normally on both sides. Blood pressure 140 by 100 mmHg in left upper limb on supine position. Respiratory rate 16 breaths per minute, thoraco-abdominal. Temperature 98.6 degree Fahrenheit. JVP normal. Examination of nervous system. Higher mental function. Right-handedness. Education status 7th standard. Occupation homemaker. Knowledge of language. She know Malayalam and English. Level of consciousness. Conscious and oriented. She is alert and attentive. Recent memory, remote memory and immediate memories are intact. Speech learned, frequency is impaired, comprehension is intact, repetition, she can able to repeat naming, reading and writing, calculation she can able to do, intelligence normal, appearance well groomed, delusion and hallucinations are absent. Coming to the cranial nerve examination, olfactory nerves are intact on both sides, optic nerve is normal on both sides, 3-4-6 nerve. There is lid retract, cannot retract the eyelids on the right side. There is binocular diplopia which disappears on closing either of the both eyes. So she has facial nerve also, facial nerve involvement. So she can't close them.
Inability to close the eyes, facial nerve. Otherwise, lid is.
Retraction, what does it mean to you? I didn't get your point, please come again.
Can't close the eyes.
Completely?
Yes, sir.
Okay.
That you mentioned only with the seventh nerve.
Okay.
Third nerve you just said ptosis present.
3-4-6 don't compare, combine with 7th.
Okay.
You're not dealing with 3-4-6.
When you mention seventh nerve, you can say inability to close the eyes or eyes are remaining open. Third nerve you just said ptosis present.
I understand that you're completely confused with 3-4. Wherever the ptosis or the lid, you're thinking about 3-4-6. There are other reasons also. Where is applicable to try to apply?
Ptosis means myasthenia, third nerve palsy or Horner's or muscle disease, where are ocular myopathy.
Sir, eyeball movements, bilateral vertical eye movements are preserved. On looking to the right, there is conjugate horizontal gaze palsy. On looking to the left, there is internuclear ophthalmoplegia.
What do you mean by that? There is a finding.
Yes, sir.
Its interpretation is internuclear ophthalmoplegia. What is the finding?
When looking towards the left, there is on right side the eyes are adducted minimally and on left
right
side.
gaze pulse. Right gaze. Facial pulse also is on right side. Gaze pulse also is on right side.
Yes, sir.
Do you remember my gaze talk? When I talked about gaze, there are two horizontal gaze centers.
Yes, sir. Frontal eye field and
One is
PPR.
AD8 and other is PPR. What's the difference between these two?
Sir,
One PPR of course, same side gaze pulse. Whereas frontal area goes control.
Opposite side.
So whenever in this case there is a right gaze pulse.
Yes, sir.
Either there should be a
Right PPR
right
lesion
PPR
or
or
left
left
frontal
So in
eye
this case,
field.
since it is a content lesion, it is more likely to be a right PPR.
Right PPR.
And facial pulse also occur on right.
Yes.
Any nystagmus you noticed?
This adduction is also minimal. Is it normal or abnormal? That adduction is at lower part. You said diagram is it looks normal.
Sir, on looking.
Let the one
Adducts minimally you say.
Yes, sir.
That means it is abnormal.
Yes, sir.
That means the medial nerve fasciculus on that side is
Also
also.
involved.
That is why there is adduction. And there is nystagmus on the abducting. So the only movement properly possible is that abducting. All other three movements are lost. So if you take half,
On and
one
off
and a half fractions are lost. So that half nystagmus fraction is. Ideally, you can mark that one also and then it will become more clear. You have put an into mark on those two. You can put one more in the mark here.
Yes, sir.
Then it will become more clear. That is the real one. So what are structures selected? If it is only PPR, that's only gaze pulse. Here it is PPR plus
ML11.
ML. That
Medial
is called
longitudinal.
1.5. Actually, it is 8.5. I would say it is 8.5.
Yes, sir. Patient also
So
involved.
7 is also there.
All of you able to follow?
So the site elevation is pons because 7 is in the pons, PPR is in the pons. MLF is actually a longitudinal structure present throughout the brain.
Throughout the brain.
But since 7 and PPR is in pons, you can finally fix the lesion in the
Pons.
It's the medial part, medial most point. Along with the motor nuclei.
MLF actually, because when MLF coordinates the actions of multiple cranial. Because when you want to look to the right, you need 1, 6 and other third. So the coordinate movement of 6 and third is done by the MLF. So when MLF is gone, coordination behind cranial system. So only one will move, other is not moving.
Sir, on the left eye, there is nystagmus on abducting the eye. It was jerky and horizontal nystagmus. Pupil are normal. In trigeminal nerve, there is only corneal and conjunctival reflex are absent on right side. So in facial nerve, right side facial nerve is affected. Wrinkling of forehead is absent. Blinking is absent. Bell's phenomenon present. Forced eye closure not able to do. Nasolabial fold is lost. They can't blow the cheeks. They can't whistle. She can't whistle.
Wrong in the
Alignment.
alignment is not wrong. Okay. Because you mentioned that. Okay, go ahead.
Test is absent.
Yes, sir. On the right side. Cirrhosis of eye present. Sir, it indicates right element facial palsy.
Lacrimation also affected.
Yes.
Morning we discussed about all the functions of the cemetery. We discussed here. Just try to look for the findings. Okay.
Vestibulocochlear nerve. Rinnis test is
These
positive
are
on
the
both
recent
sides.
presentation.
Weber is lateralized to left side. Left ear. No tinnitus, no vertigo. So 9th, 10th, 11th cranial nerves are normal on both sides. Hypoglossal nerve also normal on both sides. Sir, motor system examination, attitude of limb normal, no visible wasting, no bulk differences in both limbs. Tone is normal on both sides. Power is also normal on both sides.
You said limb involvement is there. What type of tone abnormality you are expecting?
Sir, hypotonia can be there.
Expecting hypotonia. Okay.
Is it more of coordination problem or weakness?
So more of incoordination.
Coordination are mentioned.
Yes, sir.
Usually we mention reflexes after coordination. Like tone. First you say bulge, then tone, power, coordination, then go for reflex.
Go ahead, go ahead.
Reflexes, superficial reflex, corneal reflex is absent on the right side, conjunctival reflex is present on both sides, gag reflex and palatal, abdominal, plantar is normal on both sides, plantar reflex, flexor on both sides, deep tendon reflex normal on both sides. Sensory system examination, spinothalamic sensation intact on both sides, posterior column sensation intact on both sides, cortical sensation equal intact on both sides, coordination system, cerebellar signs on right side, finger nose test she is unable to do, finger to finger nose test, left side she is unable to do, finger to finger nose test she is unable to do it on left side, heel knee
You can
test.
also instead of unable to, you can say impaired coordination or dysmetry, or you can say intention tremor. What's the finding you see, you can mention. Not able to, you can say only equal. Suppose a person has grade 0 power and hemiplegia, you can say coordination cannot be done.
Dysterodyskinesia, she can't able to do it on left side. Rebound tenderness present on left side. Tandem walking impaired on impaired. Involuntary movements absent on both sides. Gait she reads to left side. Autonomic nervous system, peripheral nerves are normal. Signs of meningeal irritation absent. Skull and spine normal. Other system examination, cardiovascular system, S1, S2 here, normally in all areas, no added sounds or murmurs. Respiratory system examination, chest movements bilaterally equal, normal vesicular breath sounds in all areas, no added sounds. Per abdomen examination, soft, non-tender abdomen, no organomegaly. Summary, a 54-year female patient, known hypertensive, came with complaints of swaying to left side, slurring of speech, deviation of angle of mouth to left for 1 month. Examination reveals conjugate horizontal gaze palsy on looking to right side, internuclear ophthalmoplegia on looking to left side, involvement of facial nerve in the form of right element facial palsy. Cerebellar signs sensor. Left side. Here,
In this case, actually, weakness can also happen on left side because corticopondocerebellar attacks minimal weakness also if you examine angle. Grade 5 power I don't completely. Is there a weakness or only attack? Crossing and tract corticopondocerebellar attacks minimal weakness is also expected. I expect there's hemiparesis on the other side. CP angle tumor pure cerebellar tumor. That is on the same side only. With the CP angle tumor, we have cerebellar on the same side. In that case, there will be no weakness. Here there is a mild hemiparesis possible because they are causing corticospinal and corticopondocerebellar. Nucleus crosses louder than here. These are tracks that cross. The crossing tracks include corticospinal and corticopondocerebellar. So minimal hemiparesis is possible.
Here the structures involved are left-sided cerebellar connections. She swayed to left. This indicates left-sided cerebellar connection affected. Deviation of angle of mouth to left and inability to close right eye indicates right-sided seventh nerve element nucleus. Seventh nerve cranial nerve palsy, mostly element. Conjugate horizontal gaze palsy on looking to right indicates right-sided paramedian pontos reticular formation affected. Internuclear ophthalmoplegia on looking to left indicates median longitudinal vesicular subfibrils. Diagnosis. It is a case of acute stroke syndrome, posterior circulation stroke. Here it is hemorrhagic. Site of lesion, brainstem probably right-sided inferior pons. Structures involved are left cerebellum, right seventh cranial nerve nucleus, right-sided medial longitudinal fasciculus, paramedian ponto reticular formation. Artery involved is basilar artery. Risk factor hypertension.
Left cerebellum directly involved. Is it?
Direct involvement,
Connection.
Tract is involved, not the cerebellum involved.
either the corticopondocerebellar fibers or spinocerebellar tract. All these are crossed tract, the spinocerebellar tract, corticopondocerebellar tract. Cerebellum is anatomically different structure on left side.
You're trying to fix the etiology or site or reason for the arterial territory as a single site and explaining both the sites' clinical findings. That's the best way. Instead of saying left side one disease, right side one disease, two arteries are involved. If you ask me practically speaking, is it possible? It's possible. I'm not saying no to that. They explain it from the exam point of view. Are you able to justify and come to a conclusion? Single artery, single site, are you able to give the explanation for the clinical science? Instead of that, saying that left cerebellum, better to mention the tracts, connecting tracts are involved, then we'll explain only one side. Get the involvement of the features. Basilar artery. Yeah, I think it's a better way on. Each case, if you see carefully, the parts to be included, all included into this presentation, third presentation compared to the second and first one. It's a better way of presentation. I'm looking about the content or structure of the case presentation, both history and the examination. I hope everybody is able to follow what we are trying to discuss here. So once again, the same point of why you're going to complete your examination, exam patient is concerned, the investigation part and the treatment point. Have you done it? Not done. So make it as a habit to do that, whatever the way of presenting, where you are going to present. Make it as a habit to write down the investigation as a separate part along with the treatment. And treatment investigation should be designed for that patient. Don't do all the complete investigation. Definitely you will not be having time to completely write the investigation. Specifically designed or customized to that patient's problem. Okay. So what are the things you would like to go for this patient? So female, hypertensive and irregular treatment you said. What are the things you would like to go for? One by one get time. Start with blood investigations. Let's start with blood investigation.
First, we start with blood investigations. We look for CBC, hemoglobin, mainly the platelet counts.
Why?
Because it is hemorrhagic, so
Okay.
blood may not flow there. Then we look for blood glucose level.
It is a new onset of
Intervention.
diabetes or it may be a stress hyperglycemia also. Okay, then.
Intervention should be done only in the euglycemic state, sir. So we look for blood glucose. Then we look for ESR, CRP.
Okay, which may not be much. Okay, young age, yes. 50 plus or 60 plus may not be required. Okay, then.
We take ECG, echo for cardiac.
So as a part of your complete workup for hypertensive patient, creatinine, urine PCR can be looked for. Okay, yes. Then ECG, echocardiogram.
Electrolytes,
Yes. Imaging is concerned.
imaging, we go for MRI, sir.
Why?
Hemorrhagic, sir. So, she is already 1 month, sir.
1 month old. Okay, yes. Then anything else? Any other investigations?
Carotid Doppler.
Okay. Management is concerned.
First, we should decrease the blood glucose level.
Blood pressure. She's hypertensive. She's not diabetic. Yeah.
Hypertension should be
control
controlled.
with the antihypertensive medications, titration, reinforcement of the complaints to the medications. Then
Rehabilitation.
rehab is going to be broad part in this patient because of the 1 month old disease. You are not going to intervene in the form of thrombolysis or stopping the bleeding, or you are not going to go for other medications. In that case, BP control, diet, lifestyle modifications, along with rehabilitation. Both for the eye part and the swaying part, she has to be given proper rehabilitation measures to overcome the problem so that she maintains good quality of life. It's very important. And it's going to periodical follow up with the BP measurements and BP follow up has to be done. Okay.